Hello, my name is Corgan Corral. I'm one of the neuroradiologists at University of Texas Southwestern Medical Center and Children's Health, practicing in Dallas, Texas. Thank you so much for the invitation to the Society of Pediatric Neuroimaging. I will be talking about suprasellar tumors and sellar tumors in the next 15 to 20 minutes. I will start first talking about how normal cell and suprasellar region looks like. I spent some time talking about the T1 shortening of the neurohypophysis when I sit down with my residents and fellows. The cella is the C-shaped structure. Anterior to it, we have the adenohypophysis, and posterior to it, we have the neurohypophysis. And the question I asked to the trainees is, why is the neurohypophysis bright? It's good to remember this because we always check its presence in all the scans that we review. So the reason neurohypophysis is bright is because two hormones that are produced in the hypothalamus, namely oxytocin and ADH or vasopressin, are transported from the nuclei to the neurohypophysis within axons. The name comes from there. It's an extension of the central nervous system, which happens to be located in the posterior cella. And these hormones are transported in vesicles whose walls contain this glycoprotein called neurophysin, which produces a T1 shortening effect in high concentrations. So therefore, when a concentration exceeds a certain threshold, we will see T1 shortening. Let's look at this now old study. This was done in rabbits. On the left side of the screen, we see the normal T1 shortening of the neurohypophysis in a normal hydrated rabbit. The one on the right shows a rabbit who was water deprived for almost 96 hours, and no longer do we see the T1 shortening of the neurohypophysis because ADH cannot be stored. It's used all the time to maintain water, to retain water in the body. When there is ectopic neurohypophysis, what we see is the hormones, the oxytocin and ADH, are going to be accumulated proximal to the site of the injury. This 9-year-old child, first of all, has a small pituitary gland, as we see over here, but also we see the T1 shortening of the neurohypophysis way up at the level of the tuber cinereum. And let's look at another example. In this case, it's more nodular, and it is more inferior compared to the one on the left side. This is a in vitro fetal study. Fetal MR shows that early on, the pituitary gland is so active, and because of the proteins in it, both the anterior pituitary and posterior pituitary are quite bright on T1. We see the same effect postnatally. In newborns, pituitary gland is going to look quite big and quite bright due to the maternal hormones traversing the placenta. This is a 3-day-old child, and on the right side we have an 11-day-old child. It is a little less bright than the 3-day-old child, but still bright, and the pituitary is quite big because of the stimulating effects of the hormones that are produced by the mother. This T1 shortening of the anterior pituitary is transient, and in approximately 2 months post-gestational age, it's supposed to be iso-intense with the brain. The pituitary gland, the anterior pituitary, is going to be iso-intense with the brain, and this is the normal progression of events in this child. So hypoglycemia is a relatively common indication for imaging in the newborn period, and occasionally we can diagnose the reason for it very easily. If we look at this T1 with sagittal images at midline, we only see the T1 shortening at the level of the tuber cinereum, and the pituitary gland, as you see, is very diminutive, unlike the normal ones we saw earlier. So this is about practice, but it has some application to our daily practice. We no longer give contrast to children who are being evaluated for growth hormone deficiency or precocious puberty. we really do not want to see the mild heterogeneity in these pituitary glands, which may potentially provoke unnecessary workup. So the thing to remember is do not give contrast for children who are being evaluated for growth hormone deficiency and precoce puberty. So now we're going to talk about the tumors. The case I like to use for this reason is the following. I use it all the time to discuss the Sellar and Suprasellar tumors and the approach to it when I sit down with the trainees. We have a 2-year-old child who presents with vomiting, and we see a big suprasellar mass, which is predominantly hyperdense on CT with multiple foci of low density, probably due to necrosis. And there's also hydrocephalus. Let's look at the sagittal T1. The first thing we need to check in these Sellar suprasellar tumors is, do we see the T1 shortening of the neurohypophysis? That will change the differential diagnosis considerably. So again, we see the large suprasellar mass, but the T1 shortening of the neurohypophysis is there, it's intact. Following administration of contrast, there is some heterogeneity enhancement. The posterior aspect of the tumor demonstrates this little cyst. And on the T2 weighted images, the solid components are relatively hypointense and on the EDC map and DWI. The solid components demonstrate diffusion restriction, indicating hypercellularity of the tumor. So we have a 2-year-old child with a suprasellar mass, and the solid components do show hypercellularity, and the T1 shortening of the neurohypophysis is intact. So what could this be? A, is this an ATRT, atypical territorial rhabdoid tumor, or is it B, polycystic astrocytoma, one of the most common tumors of the hypothalamic pituitary axis, or is it a germ cell tumor, or is it Craniopharyngioma? So let's talk about this. So again, the first question is this: do we see the T1 shortening of the neurohypophysis? If we are not seeing it, the differential is relatively short. It's going to be either a germ cell tumor or Langerhans cell histiocytosis. In almost all the cases, almost 99% of the cases, will be either germ cell tumor or LCH. And these patients will present with diabetes insipidus. If it's visible, it's a longer differential, but it's still very manageable. It's going to be either an optic hypothalamic glioma, most commonly polycystic astrocytoma, or a craniopharyngioma, or hypothalamic hamartoma, or others. So let's discuss. So this case turned out to be an ATRT, atypical territorial rhabdoid tumor. The child was 2. That's good to remember. These tumors are seen in younger children. And also, it's not going to be a germ cell tumor or LCH because the neurohypophysis is intact. And there is diffusion restriction. So it's a highly cellular neoplasm, unlike a polycystic astrocytoma. So it's not going to be craniopharyngioma because we don't have calcifications. And it's not going to be hypothalamic hamartoma for reasons which we will discuss shortly. So let's talk about germ cell tumors or germinomas. Again, we are not seeing the T1 shortening of the neurohypophysis. They enhance usually very homogeneously, and on T2 they're relatively dark. They may invade the cavernous sinus, as in this case. It's not, one way or the other for differential diagnosis. It can certainly invade the cavernous sinuses, just like pituitary adenomas or prolactinomas can invade the cavernous sinuses or the brain parenchyma. We don't always need to biopsy these cases because sometimes these germ cell tumors, if they are secreting germ cell tumors, they may secrete tumor markers, as in this case. This case was secreting beta ECG, so this turned out to be a choriocarcinoma. Again, this case also has cavernous sinus involvement on the right side, as it's shown. Also, there was a remote focus of tumor between the pharyngeal columns. We have an example of prolactinoma. We do see this in older children, usually females. There is involvement of the right cavernous sinus. And these tumors generally enhance less and later than normal brain parenchyma. Another example of germ cell tumor. This is important because that's why we check the T1 shortening of the neurohypophysis in all cases. This 2-year-old child presents with diabetes insipidus. We don't see the neurohypophysis. There is some enhancement post-contrast. So, and we couldn't see, this is an old scan, we couldn't see convincing tumor back then. So we brought the child back 5 months later, and at that time, there's certainly tumor at the floor of the third ventricle with increased nodularity and enhancement. So if we don't see the T1 shortening of the neurohypophysis in a child with diabetes insipidus, the recommendation is to repeat imaging in 3 to 6 months because a small germ cell tumor probably will declare itself in this amount of time. So this is a more recent case. This child also has diabetes insipidus, presumptive diagnosis germ cell tumor. In February, we couldn't see any tumor. In April, still no tumor. In July, no tumor. And finally, in October, there was enough tumor at the floor of the third ventricle. At that time, the neurosurgeons were able to endoscopically biopsy this tissue. So the weight really does not cause many problems because the tumor has to attain a certain size to be able to biopsy it if it's not a secreting tumor. And the treatment is not very different early on because they are simply replacing the hormones to make sure there's no that the diabetes insipidus is treated properly. So another example of germ cell tumor, the T1 shortening is absent. In a minority of cases, approximately 10 to 15% of the cases, when there is a suprasellar germ cell tumor, there will be involvement of the pineal region. The reverse is true also. If there is pineal region involvement by a germ cell tumor, in about 10 to 15% of the cases, there's going to be involvement of the suprasellar region. So we need to check both areas. Langerhans cell histiocytosis is the main differential diagnosis of germ cell tumor. They present very similarly. The only difference is LCH does not usually involve the pineal region. But other than that, if there is only suprasellar involvement, it's almost nearly impossible to sort these tumors from each other. We see thickening of the pituitary stalk and absence of the neurohypophysis in this child with LCH. Again, the differential is germ cell tumor. To sort these out from each other, if there's only suprasellar region involvement, tossing a coin works rather well. So let's look at this case. When we do brain imaging, we try to check the calvarium and nearby bones too, because there may be involvement of the calvarium. This child happened to have temporal bone involvement and mandibular involvement, relatively common signs for LCH involvement. Of course, these children undergo scatter survey or nuclear medicine studies to find out other more sites that are possibly amenable to biopsy without complications. So LCH can be nodular like this. The suprasellar LCH was like that. There's absence of the neurohypophysis, or the T1 shortening is not there. The pineal region is remarkable for a cyst. There's no tumor in the pineal region. This is a biopsy-proven LCH. There's this type of LCH, which is called neurodegenerative LCH. The prognosis is usually bad. This child was treated for LCH and eventually developed scarring in the region of the third ventricle and developed hydrocephalus. There was aqueductal stenosis. And these children are characterized by calcifications in the dentate nuclei and extensive volume loss of the cerebral and cerebral hemispheres and gliosis of the white matter. The same child's CT shows calcifications of dentate nuclei, and we end up writing this up a long time ago. A more comprehensive study is from Vienna. They discuss the parenchymal involvement of LCH. This is such a case. LCH can involve anywhere in the brain parenchyma. They may present with enhancing tissue like this one without much mass effect. This child had at least 2 foci of involvement in the brain parenchyma. So polycystic histiocytoma is one of the most common tumors of the sellar suprasellar region, and they can be easily distinguished from germ cell tumors or Craniopharyngiomas or others. The T1 shortening of neurohypophysis is going to be intact. These tumors can be massive, but these children usually do not present with diabetes insipidus, as in this case, the neurohypophysis is intact. These tumors are generally quite bright on T2 weighted images, the solid components I'm referring to. There may be cyst associated with these. And on the EDC maps, they are quite bright. Increased diffusivity, the definition of that is at least twice as much as a normal brain parenchyma, is always there for polycystic histiocytomas. Enhancement may not be always there. The cyst formation may not be always there, but increased diffusivity is always there for the solid components of the polycystic histiocytomas. If you look at this example, again, there's a very large mass, suprasellar, but the T1 shortening of the neurohypophysis is intact. The enhancement is relatively homogeneous. These tumors, although they are WHO grade 1 tumors, they are low grade. Occasionally, they may present with, or they can develop leptomeningeal spread in follow-up, as in this case, multiple foci of leptomeningeal tumor dissemination. This child, unfortunately, many years later after diagnosis, developed spinal drop metastasis also, which worsens the prognosis significantly. Craniopharyngioma is a common tumor of the suprasellar region. They are characteristic for cyst formation and calcifications. They don't usually present with diabetes insipidus, but they can present with other hormone deficiencies or abnormalities. The T1 shortening is intact, or the neurohypophysis. And the cysts may contain proteinaceous fluid, namely the fluid is likened to motor oil consistency. The calcification will look hypointense on T1 and T2. And on CT, calcifications are easily seen. The cyst walls can calcify, or solid components can calcify, and they are present little more than 90% of the time, the cysts and calcifications. The treatment of craniopharyngioma has changed over the years. Previously, the resection or complete resection was attempted. This child underwent transcallosal surgery. The tissue was resected as much as possible, but these children unfortunately develop diabetes insipidus postoperatively, and usually something called hypothalamic obesity. Now the management of craniopharyngioma has changed to more really controlling the mass effect rather than complete resection. Some books discuss bimodal age distribution for craniopharyngiomas, a peak in the younger children, another peak in young adulthood, but I don't think the age really helps, because as seen in this graph, it can be seen almost in any age. Another example of craniopharyngioma, the cysts. Occasionally, catheters are placed, and a Meyer reservoir or Rickman reservoir are placed into the cyst cavity to control the secretions, and also phosphorus, diluted radioactive phosphorus, can be introduced via the reservoir to control the cyst wall cellular activity. Craniopharyngiomas can be extracellular, as in this case. This is sphenoid sinus craniopharyngioma. The sinus is expanded, and there are cysts and calcifications, just like there would be in a suprasellar craniopharyngioma, but the pituitary gland itself looks normal. Hypothalamic hamartomas are interesting tumors because they present with gelastic seizures, the inappropriate behavior, or laughing seizures. They can be sessile or pedunculated, as in this case. They can be either isointense to the brain parenchyma, or occasionally hyperintense on T2 to the brain parenchyma. They usually do not enhance. This is a pedunculated hypothalamic hamartoma. The previous one was a sessile one. And now they can be treated with laser rather than resection, the latest treatment for these hypothalamic hamartomas. So if we go back and review what we discussed so far, the first thing we do is we check whether the T1 shortening of the neurohypophysis is there or not. And then by simply using the imaging characteristics, the presence of calcifications, cysts, increased diffusivity for polycystic astrocytoma, the clinical history in hypothalamic hamartoma, and also the isointensity or T2 prolongation in hypothalamic hamartoma, and in other tumors such as ATRT, again, diffusing characteristics will help tremendously in making the diagnosis successfully in the tumors of this region. Again, I'd like to thank the SPIN for this invitation, and I think I was able to finish my talk in less than 20 minutes. Thank you.